Welcome to this rapid clinical briefing on dialysis and heart failure. We're going to cut right through the noise and give you the high-yield info you absolutely need for rounds, for the ICU, and for making safer calls right there at the bedside.
Okay, let's start with a scene we've all lived through. You're on rounds, you've got a fluid-overloaded patient with a failing heart, and your attending turns to you and asks this exact question. What do you say?
Here it is. This is your answer, the single most important rule. It's not about how fast you can get the dialysis done. Not at all. It's about whether the patient can actually tolerate it. You are in a constant balancing act between pulling off fluid and making sure the patient's cardiac output and organ perfusion don't crash. So, if stability is our main goal, let's break down why our usual go-to, intermittent hemodialysis, or IHD, can be so risky for these folks. This is the big trap we really need to avoid. So, here's the dangerous chain reaction that gets kicked off. When you pull fluid off too quickly with standard IHD, you crater the patient's preload. Now, in a healthy heart, no big deal. But in a failing heart, dropping that preload tanks the cardiac output, and that leads directly to hypotension.
And that, hypotension, it's not just a number on the monitor. It causes renal hypoperfusion, which can make the very AKI you're trying to treat even worse. And on top of that, you're rolling the dice with potentially life-threatening arrhythmias. It's just a vicious cycle.
So, this is the crucial point. If you remember nothing else for your next exam or your next shift, burn this rule into your brain. When that patient gets hypotensive during dialysis, your first thought shouldn't be, let's get this over with. It should be, we need to slow down the rate of fluid removal. Okay, so we've made it pretty clear what the problem is with standard IHD. So what are our better, safer options for these really fragile patients? We've basically got two main alternatives, and the theme is super simple. Go slower. By stretching out the therapy from, say, 6 to 12 hours for slow, low-efficiency dialysis, or SLED, all the way up to a full 24 hours for CRCT, we can pull that fluid off in a much, much gentler way. You know, for a lot of your heart failure patients, SLED is going to be the perfect sweet spot. That slower rate gives the body time for fluid to shift back into the blood vessels, what we call vascular refill, and that helps keep the blood pressure up. This is exactly why it's so much better tolerated in patients with a low ejection fraction or RV failure. But for your sickest of the sick patients, especially the ones in cardiogenic shock or on pressors, CRET is the absolute gold standard. Because it's running continuously, it gives you the most gentle ultrafiltration possible, maintaining a stable preload and avoiding those really dangerous swings in blood pressure. So we've been talking a lot about the duration of the therapy, right? But there's an even more fundamental variable you need to be watching like a hawk. Just look at the relationship here. It's pretty obvious. As the time goes up, the hemodynamic tolerance gets better. But why? Why is CRT better tolerated than SLED, which is better than IHD? What's the real factor driving this? So what is it? What's the one number, the one parameter that truly decides whether your patient stays stable or crashes during fluid removal? It's this number right here, the ultrafiltration rate, the UF rate. As a general rule of thumb, you want to stay below 10 milliliters per kilogram per hour. And honestly, in your heart failure patients, that safety limit is probably even lower. This is way more important than how long the session is. A gentle rate is everything. All right, let's get to the most practical part of this whole briefing. These are the red flags you need to be looking for at the bedside to know when you have to slow down or even stop the therapy altogether. This is your bedside safety checklist. If that mean arterial pressure drops below 65, even with pressors, if you see the lactate starting to climb, or if the patient suddenly gets confused, you are seeing signs of end organ hypoperfusion. You have to act, and act immediately. Slow the rate, maybe give some fluid back, but do not try to push through these warning signs. Now, here's a pretty advanced ICU concept you should know about. You might see the creatinine start to bump up as you're pulling fluid off, and your gut instinct is to panic and stop. But this can be what's called permissive AKI. It's a hemodynamic effect, not new structural kidney damage. The key here is to stay focused on the real goal, successful decongestion. All right, let's wrap this all up. We've talked about the risks, we've talked about the tools, and we've talked about the safety checks. So what is the one single overarching principle you need to walk away with? This is the fundamental shift in thinking you need to have. It's not about being efficient or saving time. It's about finesse and stability. Your job is to support that struggling heart by removing fluid as gently as the patient's hemodynamics will let you.
And there you have it, your perfect one-liner for rounds. It proves you get it, that tolerance is the real limiting factor, and you know exactly which tool to grab based on how stable your patient is. Master this, and you'll be managing these super complex cases with a ton more confidence.